Just wanted to let you guys know we'll be starting here in a minute. Also to remind everyone, email me, text me, let me know that you were on so I can put your name down as attended and put you in the attendance roster. If you're logged on through your service, let your service know so they can send me an email of everybody that was there. So we have,
Barry.
huh?
Hello, Barry.
I got you. Hi, Dr. Lynn. I got you. So we're going to head and call the meeting to order. It's 9 o'clock. We'll get started now. Our first order of business is a STEMI report by Brenda Williams, and she is here.
Believe it or not.
I don't need a microphone.
Oh, okay. I stay in this room.
Yeah, stay. You just stand right there. Thank you.
They have to see me.
Oh yeah, they do.
Gotta believe I exist. Well, good morning. I'm Brenda Williams. I'm manager of 2 East A now. I was manager of 2 West. I'm now manager of the inpatient telemetry, and I'm also the chest pain coordinator. So we'll get right started with our EMS run. This one started at 6:53 in the morning. I received the call that an 86-year-old woman complained of chest pain and some difficulty breathing. At 7:18, they arrived to the patient. Patient stated that she had had difficulty breathing for the past couple of days and that today it progressed. Her initial SATs were 85% on room air. Sillyville, can't say that, Sillyville Fire, Sillyville Fire had already arrived and they applied 4 liters nasal cannula to improve to 90%. Patient had been advised to take 2 nitro prior to EMS arrival. So, and she did have some relief with that. Her cardiologist advised that she'd be seen in the ER today. So by 7:20, they established an IV. I didn't see anywhere where they'd given any fluids or anything along those lines. By 7:24, placed a non-rebreather at 15 liters per minute, and that improved her ability to breathe, and her SATs were up to 98%. By 7:25, a 12 lead was obtained, showed an inferior depression with slight ST elevation. It was noted in the ABL only. Her vital signs were 141/78. Heart rate was 76. Her respirations were 22. She was not complaining of any pain. Her blood sugar was 227. Patient was able to stand and walk to the cot with no difficulty. Her medications were also transported with her on her cot. She had a history of a cardiac stent, diabetes, and hypertension, and she was also taking Plavix. By 7:38, he did repeat some vital signs, got 136/58, a heart rate of 78, respiration of 20. She had multiple 12 leads and they had no change. They all said the same thing. I didn't see where it was transported to or sent over to Union, but I can assume it was. By 7:53, they arrived and transferred her care to the RN at Union. She got down to the cath lab at 9:04, balloon access. They got a balloon across the lesion. It was successful. Sorry, I had to go ahead.
Yeah,
Very smooth.
you're good.
Successful PTCA of the ramus intermedius branch, which is an artery which rises from the left main coronary artery between the left anterior descending artery and the left circumflex artery. It reduced the 100% stenosis to 0% residual. Her pre-hospital EKG to balloon time was 99 minutes. Her door to balloon was 71 minutes. She was released without chest pain and shortness of breath once weaned off her O2 4 days later. And then we do have our summary of door to balloon times for the year. We did drop a little bit in June to 83%. And then you'll see we also dropped in September to 67%. We're still year to date at 93. December information is not back yet. We typically run probably a month, sometimes almost 2 months behind on getting our information. So by the next one, we'll have all of 2021 to be able to report. Be over 90%. Yeah, so I'm still doing well. I know we've had years where we're 100% across the board and we like those years.
Any theories on those drops?
What's that?
Any theories on those drops?
No, we have a gal, Angie, who does all of the quality, who does all of the checks to see those kind of drops. Typically, she sends them to me. I don't know if just because due to busyness, I've not received. Typically, they'll send them to me and say, hey, you want to look into this one, delve in and see what's going on. But I didn't get anything. So
Interesting to see what the fallouts were.
yeah, so we don't quite know what
Yeah, because
those
both
are.
of those were very high volume days for us ending this.
Yeah. Oh, really?
Yeah, absolutely.
Okay.
Yeah.
Well, they'll say they could coordinate.
Actually, in September, I think, so we had our internal disaster.
It was. Actually, it was.
Was it? Okay. Well, thank you. This couldn't be done without you, so we do appreciate it.
Thank you, Brenda. Appreciate your help. Moving on, it's going to be Jackie Martin with our trauma report, and then Dr. Malama is going to present after that.
Okay.
It'd be a very short meeting, guy. Well, no, Jackie's gonna talk this.
So I did things a little different this time. I only pulled one run, and I actually pulled a transfer, and I did it on purpose for two reasons. I want you to remember that transfers are still EMS runs. And to show you the difference between the trauma and the non-trauma, but that not that anybody did anything wrong, because they absolutely did not. So this is an 85-year-old female. Family actually called EMS to a private residence for some type of traumatic injury. I got that right off the EMS report because I really didn't know what was going on. Patient was found sitting in a wheelchair, but she was responsive to verbal, but she was very confused. Her answers weren't right. So yeah, not doing real well. She was in no acute respiratory distress. She had good skin color. Her daughter said that she had actually fell 2 days before, and they went to a hospital, but it was not a trauma center. They told her that she had a fractured nose and that the CT was negative, and they discharged her home, but she was still confused and complaining of a severe headache. So those are huge red flags. Today, she's even more confused. She's alert to only herself. She's giving them inappropriate answers. She's just not responding right to them. And so that's actually what prompted the family. And from what it looks like, this was a normal home situation, a normal family, but that's actually what said, hey, we need to call for help. EMS did do a stroke scale on her, and it was negative. They note that she has a patent airway, that her radial pulses are weak and thready. That's another huge red flag. She's hypertensive and tachycardia. There's another red flag. They put her in a C-collar, and in the report it says they did it due to her age. I probably would have done it due to mechanism of injury, but okay. And they moved her to the cot. She has a Glasgow of 13. They do keep her head elevated. Kudos for thinking about that. And her end tidal is, quote, somewhat low. So they give her an IV and some Zofan because she is very sick to her stomach, which is another red flag. Finger stick is, quote, somewhat high. 12 leads show, they say, is AFib with RVR and a right bundle branch, and her race score is 0.
Zero. They had 0 numbers. They just had a
Somewhat.
finger stick in that.
Yep.
Interesting.
So her vitals, if you look, are stable, but when you think about the overall scenario about what happened to her and what we think is going on, hypertension and tachycardia are bad things. And then hypertension and tachycardia become hypotension, and now you're really behind the 8 ball. So her Glasgow is documented as 11. Her pressures start out in the 160s over 80s, and then they start dropping. They do call a trauma alert when they bring her in. She's an ED to ED transfer. They bring her in and do at least alert us to a trauma. So she comes in, we call a level 2 activation. Again, she fell 2 days before from standing. She's on Eliquis. That is a trauma nurse's nightmare right there. She was seen at a non-trauma center. She was discharged home with a negative CT per the family. At this point, we don't have the CT results, but it is possible. Family watched her very closely. Good thing they did. She was complaining of a severe headache, increased fatigue, delayed responses. So that just shows you that that was progressing. About 3 hours prior to arriving, family noticed, quote, significant cognitive changes. So grandma was not doing well. So when we get her, she is relatively stable vital signs on paper. She's alert and oriented ×1, so she's not doing well, even though her vitals are holding. Her pupils are doing all right, and the ED doc actually charts that she's in no observable distress. So we do another CT, and not only does she have a subdural hematoma, but it started to shift, and that's a big shift. 6 millimeters is big. So she's still maintaining her own airway. We give FEBA because it will reverse those effects of Eliquis, and I'll talk a little bit more about that here in just a minute. And we actually airlift her out to IU Methodist. She's a big fat head bleed with a shift. At IU, she gets a left craniotomy, and then she starts to decline post-op. So the family says, you know what, we're gonna stop. And so they choose comfort measures, and she did die 2 days after she left our ER here. So first of all, I wanna make it very clear that the outside hospital did not do anything wrong, because in elderly head bleeds, they don't always show up. So what we typically do here is we keep them for 24 hours, repeat the CT in the morning, and then look for differences. But this was actually 2 days later. They assessed this patient, and based on the findings they had, they made a disposition decision, okay? They don't have the trauma criteria that we have in place. So they're trained, but they're not as honed in on that stuff as we are. So a Glasgow less than or equal to 11 with a known traumatic injury is an automatic activation for us. High risk for falls greater than 65 and on anticoagulation is an automatic activation for us. So both of these is what got us a level 2. Had her vital signs been unstable, she could possibly have been a level 1. So trauma centers, all trauma centers have guidelines in place. They're established. They're very similar to your protocols. They're very injury specific. We have some for head injuries. We have some for rib fractures. We have them for all different stuff. So we activated the blunt head injury guidelines for geriatric patients that are anticoagulated. So because she was over the age of 65, that included her. She was on anticoagulation. She took Eliquis. She suffered a head injury with or without loss of consciousness. She had mental status changes and a history of a direct impact to her head. So that definitely bought her the guideline. So what we do here is we activate a trauma team, and based on the level of activation, you get either a small team or the large team. She was assessed by the RN within 15 minutes. Actually, probably the minute she arrived, that assessment was started. She was assessed by the provider within 30 minutes, and it was done within a few minutes. We include the Glasgow and vital signs in that assessment. We get a CT of the brain and have it read within 60 minutes. It's actually arrival to 30 minutes to get the CT and then completion to read within the 60. We get stat baseline labs and EKGs and CTs. We put her in fall precautions. We consult trauma and or neurosurgery. If there's a reversal to be used, we use it. We used FEBA this time. Sometimes we use other forms. And if for some reason that day we don't have neurosurgery because we don't have it all every day, then we would have transferred her to a level 1. And I do think that's what happened this time. Excuse me. So let's talk a little bit about a subdural. It's an abnormal collection of blood under the dura mater, remember? It's typically from some type of head trauma. It can be small bleeds, which can actually resolve spontaneously, or it can be a larger bleed, which leads to herniations, which are the shifts. Subdurals can mimic strokes. They can mimic dementia, and the EMS people looked for both of those. It can have subtle presentations like mild headaches, subtle mental status changes, gait disturbances, and she had them all. It has to be considered in any older person with an altered level of consciousness, altered mental status, especially if they're prone to falls, because they don't always tell you that they fell, or we don't always know if they fell. And then the anticoagulations push them to even higher risk. Subdurals often come with a clear history of trauma, followed by headache and altered levels of consciousness, but you don't always get that information. You guys know that. You've been on scene where you've asked, the family's like, we don't know. They live by themselves. We found them like this morning. Patients commonly present with a lucid period and then they deteriorate. So they're like normal and then all of a sudden they're not, which is exactly what this lady did. Acute subdurals happen in about 17 to 38% of cases, and it's something they call talk and die. They're normal and then they're not. And when they're not, it's a very rapid thing that happens and they crash very fast on you. If they have a subacute subdural, a lot of times they'll complain of a worsening headache that can happen up to a couple weeks after the trauma. So it's just this slow bleed that just continues to keep going. So most commonly they present with a headache. About 90% of your patients are going to have a headache, mental status changes, and hemiparesis. The description of the headaches are all over the place. Sometimes they're just a generalized, severe with sudden onset. And I would tell you, myself included, we tend to blow off headaches, especially living in the Midwest with weather changes. They'll have nausea and vomiting. She complained of nausea. They gave her Zofran. They'll have mental status changes that can come on and look like dementia, mild confusion, all kinds of places they can be on the level of consciousness. And she did do that. So we gave FEBA. FEBA is an anti-inhibitor coagulant, and we did it specifically to reverse the effects of the Eliquis. It can control and prevent bleeding episodes. A lot of times it's used around surgical procedures. It can be given routinely to prevent or reduce bleeding episodes in people that are really high risk. But in trauma, we use it specifically to reverse the effects of that anticoagulant. So they were on FEBA, we are on Eliquis, so we gave them FEBA. So would a trauma center have changed this? Nobody will ever know. You really don't know. She went to the nearest facility. She got perfect treatment. She got great care. The family chose not to be aggressive at IU. They discussed further surgery. They went in depth with things. So we don't know. We really don't know. The only thing I think that I could probably say is that she probably would have been at IU a little quicker. And I could just about guarantee you we would have kept her for at least 24 hours. However, if you remember on the first slide, it had been 2 days since she fell. So Do I think it would have changed? I really don't know. So how does this relate to you? Well, it supports your CDC algorithm about taking patients to the highest level of care, okay? So I realize that some of you live in areas where there are no trauma centers, and that's okay. That is perfectly okay. The highest level is a 1, which is currently our IU health system, our Riley, Eskenazi, those people. So we understand that you can't get them to those trauma centers. However, if no trauma center is available, then it's fine to stabilize and transfer to the closest facility, okay? And sometimes even with the best care, bad outcomes happen, which is what happened in this place. All right,
I'm not sure.
I don't think it would have changed.
At that age.
I really don't
and
think it would have
for-
changed it a
yeah,
bit.
I really don't. Thank you, Jackie. Appreciate that very much. All right, so I'm going to stop sharing right now, and Dr. Malamed is going to take over. You got it, Matt.
Thanks, Barry. Hi, everybody. Let me get rolling. Just tell me, can you guys see my screen?
Yes, we're good.
Fantastic. And it's in presenting mode for you guys.
Yep.
Yep. Okay. Awesome. Great. So thanks so much for joining us. Everybody wanted to review this. This is a little bit of a takeoff from a case I recently took part in, and I thought it was a good way to kind of put two things together and review some things, especially things that we don't typically do that often. So let's start with a quick case. So this is a 64-year-old male, past medical history of hypertension, diabetes, high cholesterol, smokes a pack a day for the past 40 years, got called out for some chest pain, shortness of breath, and nausea. When you guys get there, you find him to be diaphoretic. He's a bit tachypnic. He's got a heart rate of 82. His belly is nice and soft. He's got no pitting edema, and he's awake while he's talking to you. Vital signs are fairly overall stable as far as you can tell, or within normal limits in front of you. You do a 12 lead. Oops, sorry. You do a 12 lead. If I could go to the 12 lead, you do a 12 lead, and that's what you get. And so take a look at that, see what you think. What should we be most concerned about? Anyone have an idea what this EKG is showing? Yell it out. Unmute yourself and go ahead and yell it out.
Inferior.
I got an inferior. Anybody else? I hope most people see this fairly obvious inferior semi, right? So you have ST elevations in 2, 3 in AVF. You have some reciprocal starting in 1 in AVL, right? And also a little bit in V6 is starting to kind of change, but nothing much there, but really 2, 3 in AVF. And in this particular case, if you look at it, 3 is slightly greater than 2 in those settings, sometimes fairly more concerning for this fairly significant inferior semi. So, and looking back at it, you do have about a 35-minute transport time. So en route, you start some large bore IVs. You already gave him some aspirin. You started some fluids. You gave him 4 of Zofran for some nausea that he was having. Given the morphology of the things, to remember that inferior semis are typically very preload dependent. So some people will tell you, again, this is case by case basis, but in this particular instance, we withheld nitro solely because it's a fairly significant inferior semi, because again, they are preload dependent. Some people will tell you they can give nitro. So, you know, depending on the BP, I have given nitro to inferior semis. So you don't have to necessarily say we cannot give that in that particular case. But we've got a fairly clear cut inferior semi. We're en route, we're going to the hospital. About a little bit into your ride, you decide to do a repeat EKG because the person becomes a little bit more altered and you get repeat vitals. His heart rate is now for you in the 30s. His BP is in the tanker. He's becoming more tachypnic and you're like, oh my God, why is this guy altered? So you check his BGL. His BGL is fairly fine. What do you guys see on the, let me move this over in case this is in front of your screen. What do you guys see in terms of the EKG now?
More elevation.
More elevation. Okay. Is there anything else of concern here?
Might look like biphasic T waves almost, V1 through V3.
Okay.
I don't know if that matters.
He's very
Let's-
Brady.
Okay, he's very Brady. Good. I like that you've noticed that he's very Brady. Sure. What else? Look at the P waves. Are your QRS complexes or P waves preceding each of your QRS complexes here?
Yeah, they disappear. They're not coordinated.
I think I heard it. So what are we seeing really here?
We're wondering if he's in a third degree.
Third degree.
There we go. Right. So the concern here, because if you for those of you who may not be seeing it, the P's are not preceding every QRS complex, and they're kind of just marching out at their own pace. So if you look at it, you've got a P here and a QRS complex that really has almost minimal relation to that at best. Another P wave here, no relation to that QRS complex. Same here, P wave here, no real relationship to that QRS complex. Another P wave here, no relationship to that QRS complex. P wave here, nothing to that one. And lastly here, if you look at it. So really what this guy is he's got an inferior semi that is now in third degree block. And so, and he's becoming hypotensive, he's altered. So what we decide at this point is well, what do we do, right? We've given him fluids. Fluids aren't gonna really make the block better. And so really then the question is what are our next best steps for this particular patient, right? What can we do? So yell them out. What would you guys do in this instance? You're looking at a patient, they've got a STEMI, they're becoming hypotensive, they're becoming altered. What's in your wheelhouse that you're able to do on the bus before we get to the hospital?
Pace.
Okay, I got pace. Anything else? We have nothing else to throw at this guy? We throw water at him, a little holy water.
Atropine is contraindicated in a third degree, so.
Okay, all right. I'll take atropine, but it's contraindicating this particular instance. Sure, right. So atropine isn't going to do much in a third degree block. That I totally agree with. But for any like symptomatic bradycardia, we can consider atropine. Anything else we can do? Well, let me go to the next screen and we'll discuss, and then I'll touch base on what we think the next thing. So what does this guy have? This guy obviously has symptomatic bradycardia. We've got a fairly decent cause in this particular instance where they're having a STEMI, their SA node fairly well fed by that right circumflex artery, which is kind of predominantly in that inferior STEMI region. So once you knock that out, they've lost their SA node. Now they're really only kind of having an intrinsic electrical activity out of their AV node. That's why they're fairly bradycardic, right? So, but let's kind of broaden our logic that it's not just STEMI that can cause symptomatic bradycardia, and it can be a number of different things. And they're all mostly on the screen. The things to touch base on, the things that I think you should definitively keep on your radar whenever you see a patient and go, why is this person so bradycardic? Obviously, one of the things, so we know those people who become significantly hypoxic and are in respiratory failure and respiratory arrest will start bradying down, right? And that can be one thing to always keep on the back of your head. Electrolyte disturbances are probably one of the most, the next second big commonest reason that we'll see things, especially in our end-stage renal disease patients. So those people who've got potassiums in the 7, 8s, 9s even, we may present with significant significant bradycardia. Other things, same thing are overdoses or accidental overdoses. So people who take digoxin, people who take beta blockers or calcium channel blockers, or any of our some of our other antihypertensives. Mixed edema coma, which is the extension of significant hypothyroidism, may present with just simple bradycardia. And especially in this weather that we have, hypothermia will easily lead to bradycardia as well. And a bunch of other things that, hey, you may not think about, but they're all fairly here. And so whenever you're presented with bradycardia, you got to think to yourself, what's going on and why is this being caused and what should I do in this particular instance? And then what can we do if we're presented with it, right? So obviously the first step that you can do is you've got your IVs established or an IO, you can give atropine. Yes, is atropine not really going to be effective or really utilized in a third degree block? For sure. Have people given it? Yes. Is it going to change a ton? No. So I don't think there's a ton there, but you can give atropine. And in the pre-hospital setting, we can do transcutaneous pacing, right? In the in-hospital setting, I can do a transvenous pacer, right? I can put a central line in and then float a pacing wire into their right atrium, and inevitably down kind of through and into their right ventricle and pace them that way. And lastly, we also always have the option of adding pressors, right? So we have inotropic and chronotropic pressors. Chronotropic gives us better squeeze. Inotropic pressors give us a better rate, right? And some do both really well, some do one really well, some do the other. So you always have the option to do pressors. So taking back and looking at it, and we've got a fairly long transport time. We've got an inferior semi with somebody who is actively bradycardic and starting to become altered. We really can't give atropine to this patient because it's not really indicated in a third degree block. But what do we have next in our arsenal to kind of take care of this patient is pacing the patient, right? And so when should we pace the patient is obviously in those particular instances where we have somebody who have what we call sinus node dysfunction, right? It's a kind of nice catch-all term for all those bad things going on. And when their symptomatology is fairly consistent with their bradycardia, right? So their bradycardia is causing the symptoms that they're having. And so in those particular instances, we want to think about, hey, maybe we should start pacing this particular patient. And so how do we pace this patient? And there are a couple of logical reasons out there. You can read a bunch of articles that will explain to you of doing one way or the other. I'm going to present to you both. Both are fine. Both are appropriate. One doctor will tell you one thing, another doctor will tell you another. And I think both are fairly logical ways to approach it. So the first thing you do, so almost everyone's got a Zoll or any other kind of life pack with them. You're going to attach the pads to your patient. Now, ideally, if you can, putting them in the AP, right? So the anterior, posterior, kind of sandwiching that heart would be the most ideal in terms of electrical activity. Now, if you can't, because of either body habitus or the way they're lying, or you're unable to move them or something along those lines, the anterior lateral position are perfectly fine too. If I were to prefer one versus the other, I'll take a sandwich AP versus then I will take the anterior lateral. Connect those to your life pack or your Zoll. And then what you're going to do is you're going to set, and the reason I didn't put pictures of this, everybody has some like different devices. So I try not to kind of put that so you don't go, well, that's not the device that I have. So I didn't want to kind of anchor on one device versus the other. They're almost all fairly similar. So you're going to attach the pads to the patient. You're going to turn on your pacing function. Some systems have a demand or a set rate, right? Ideally, in these particular instances, I tend to go with a set rate versus a demand. Demand means that the person will have their intrinsic rhythm, and then the pacer will provide extra beats on top of whatever their intrinsic rhythm is. So for example, if I set it to 70 and their demand is, and their intrinsic rhythm's around 30, the system will provide, the life packers all will provide 40 extra beats on top of that. And that's not kind of ideally what I want in some of these instances. Some of these instances, I just want to have, I know this person was consistently going to get 70 beats per minute at this setting. So I try to go with just a fixed rate. So most people will start around 70. Sometimes you need to increase that to increase either perfusion, end organ perfusion, mental status changes, etc., depending on kind of what's in front of you. And then so you've attached your pads, you've set your rate, then you're going to set your milliamps. And this will have two different versions. Some people will tell you to start low and just go up until you have capture. Some people will say start high and start decreasing until you lose capture and then go back up about 5 or 10 milliamps. Either birth is perfectly fine. I've done both. I think every case by case scenario will have that setting to think about in terms of, hey, should I start high and go low? How acutely altered or how acutely sick is this particular patient in front of me? So use that as a judgment, but both are perfectly fine. I've painted it here where you're kind of starting low and going up. You can do both if you think are appropriate. So you're going to go ahead and start increasing those milliamps, usually by about 5 or 10 until you get capture. And I'll explain to you what capture looks like in a moment. And if you don't get capture, right roughly when you get to about 120, 130, 150 milliamps, you tend to go up to about 200 typically. But if you don't get to about 130 or 140, probably what you want to consider is repositioning those pads so that you can kind of see, hey, maybe I'm just not getting captured because of where it is or the body habit is or something along those lines. So try and do that. And a lot of times what they'll do is so you'll go up to capture, let's say you get capture at 70 milliamps, tick down 5. If you lose capture at 65, then you know probably at 70 you're good. I would go up to 75 just to give you that definitive threshold, then I'll know I'll always have capture at 75. Because at 70, if that's like, hey, I get capture, but maybe I lose a beat here or two, you want to go up by about 5. And then, and lastly, kind of remember that pacing can be painful, especially if the patient is awake, right? So consider pain medication. You have a gamut of things that you can give depending on what's out there. People have given ketamine, people have given fentanyl, all are fairly appropriate. Some people have given Versed. All of those things are fairly appropriate medications in the setting of pain control for pacing. And if any of you guys have any questions, just shout them out. I'll be more than happy to stop talking for a second about any of those things, what I've said so far. Any questions about this method of pacing? You don't have to have a question. It's okay if you don't. I'm going to keep moving along. If you do, let me know. We'll go from there. Yes, sir. All right. I think that is nope. So, shrink that back down. Great. So, what does it look like when we actually get capture? So here are some variations of what capture doesn't look like, and then inevitably what capture does really look like. So if you start seeing these pacer spikes, right, with these large, what you think are almost QRS complexes, that's really not capture. That's just the pacer spikes firing and trying to get some sort of electrical activity, but it does not appear like capture. Same thing here. You're getting these huge pacer spikes, right? And then a depolarization, but no actual capture. Lastly, same thing here, right? You're getting these huge pacer spikes, but no capture associated with it. And really what we're seeing here is this true capture. And really what this is pacer spike and a QRS complex right afterwards. Pacer spike, QRS complex. Pacer spike, QRS complex, right? So this is what we're looking for. Now this morphology may not look always the same, and I'll show you another one that looks slightly different. But what you're looking for is a pacer spike followed by a QRS complex. If you don't have a pacer spike followed by a QRS complex, you probably don't have capture in that particular patient. And again, here's another look at what does it look like when we don't have capture versus what we have when we do have capture. See here, you have a pacer spike, and then this is probably an intrinsic rhythm, right? Because they have a P, a QRS, and a T. This is likely not secondary to the pacer spike itself. Same thing here, pacer spike, P, QRS, T, pacer spike, P, QRS, T. So again, this person does not have capture. While down here, you can see there's a definitive pacer spike, and then a full QRS complex, pacer spike, full QRS complex, pacer spike, full QRS complex. So this particular patient does have capture. So that's really, so looking at the previous one, right? Morphology looks different than the one I just showed you, but they have QRS complexes following each of these pacer spikes predominantly. This is the QRS. So that's your pacer spike. That's the QRS complex. That's the pacer spike. That's the QRS complex. All right. Same thing here. Pacer spike, QRS complex. Pacer spike, QRS complex. So that's what we're looking for in terms of capture. And then what do we do if we can't capture? You know, we've done all these things. We've tried everything. Why are we not getting capture? And in this particular instance, we have to say to ourselves, well, what are the reasons we're not getting capture? Is it because the guy is super hairy, right? Are we trying to pace a bear? If we're trying to pace a bear, time to do a little bit of a wax job, right? Take those pads, mash them down really firmly, rip that guy's or girl's hair off, and then put some new pads on in the place, and hopefully that'll work. The other thing that you get, other problems, especially these people who are fairly sick and sick appearing, is maybe they're fairly diaphoretic, and we got to dry them off a little bit better. So try and do that. You want to try and dry them off with a towel, and then put new pads on, because those pads that are fairly kind of wet from diaphoresis aren't going to stick super well. And then lastly is body habits. So those people who are kind of barrel chested are kind of pink puffers and blue bloaters from COPDers especially. Those people may not get great capture because there's more impedance associated with their body habitus, both either from fat or distance from the chest wall to the actual cardiac muscle. So in those particular instances, you may want to kind of reposition things, or actually have somebody see if you can mash down the pads. That sometimes can provide a little bit better pacing comparatively. And lastly, if, you know, despite everything you've done, you've looked at the patient like, man, we're trying to do everything we can, we're not getting capture. Sometimes you want to consider just trying to see if, hey, will a pressor get us there in terms of both either chronicity, inotropy or chronotropy, or both. right? So epi or norepi are your options. Yes, in the setting of a STEMI, may this cause slightly more heart damage in terms of cardiac muscle usage because the cardiac muscle is going to work hard. Sure, that is the case, but you can't really revive, someone who's dead and who has either brain ischemia secondary to poor perfusion and poor oxygenation. So just be wary of that. Is this ideal? Not the most ideal, but is there any other alternatives? Not really that much. And honestly, the one thing I forgot to mention here, and I forgot to mention from the previous slides, obviously, if it's a hyperkalemic patient, here you're looking at a patient who's a end-stage renal disease patient and they've missed all their dialysis like the 2 past weeks, giving some calcium right off the bat would probably be the other thing I would think about. And you sometimes will see that QRS complexes will start kind of reappearing and narrowing. And so that's how you would troubleshoot your patients. And that is roughly it. And these are kind of some of the things here in terms of my references. Any questions about the pacing of a patient? All right. Well, if there's no questions, and if you don't want to ask a question in public, you want to email me or text me or call me, feel free anytime. Be more than happy to answer any of your questions for you.
All right, Matt, thank you. Anybody have any questions or anything they'd like to bring up? A couple things I want to bring to everybody's attention just to make sure you're all aware of what's going on. Okay, so don't forget if you have not gotten all of your certifications to your providers, we need to make sure that you all have your BLS, your ACLS, your PALS, ICLS, and or PHLS by the end of March. If you know that you don't have those or you're going to be expired by that point in time, get with your supervisor, get with your director, manager, whatever it is, and get that taken care of. We have to have that or you're not going to be able to work in the system as of March 31st. April 1st comes around. That's not an April Fool's joke. That's the way it's actually going to be. All right, we're going to make sure that everybody needs to have what they need to have. Additionally to that, I know it's a few months away, but EMS week is going to be coming up, and I'm going to be looking to maybe do some type of EMS outreach, maybe a symposium or some type of EMS games or obstacle course or something like that in the summertime, so y'all can die and I can watch in the summer. So, but I'll get some people to judge it. I think it'd be kind of fun to do something. If you have any ideas or something that you think would be really cool, email me and let me know. I'll open for suggestions for something just to try to get us all out of the buildings and get together and do something. Could be around EMS week, could be after that. I don't mind. It doesn't make a difference to me. And last but not least, please be sure and email me, text me, let me know that you're online right now in order to get added to the attendance list. Anybody in the room have anything they'd like to add? All right, so that's it for the day. A little bit shorter than normal because we didn't have a stroke report. If you have any questions or not sure about something, either email or text myself or get a hold of Dr. Malamed and he can answer questions. Jackie can answer any questions. Brenda's amazing. Everybody's amazing and they can do anything that you need. So otherwise, I'm going to stop sharing and end this meeting. Have a great week and a good month.